I'm John Michael Herndon, and I'm a PGY1 resident at Princeton Baptist Medical Center. My research is the assessment of outcomes in patients with end-stage renal disease and congestive heart failure following fluid resuscitation for sepsis and septic shock. I have nothing to disclose. The Surviving Sepsis campaign recommends a 30 milliliter per kilogram fluid bolus for septic patients with initial hypotension or patients with septic shock. However, there are no recommendations based on comorbidities in which volume overload would be a particular concern, such as end-stage renal disease and congestive heart failure. Historically, there has been a positive outcomes evidence of fluid resuscitation in such a patient population. Previous studies have more so assessed adherence to guidelines, which showed that providers may be more hesitant to fluid resuscitate these patients as recommended. The CMS SEP1 core measure assesses facilities fluid management in septic or septic shock patients using the previous Surviving Sepsis campaign recommendation of a 30 milliliter per kilogram fluid bolus within 3 hours. Again, for patients with severe sepsis to qualify for the fluid bolus, they must have initial hypotension. All patients with septic shock should receive this fluid bolus. Septic shock is defined as provider documentation of septic shock or severe sepsis criteria and either hypotension after the initial 30 milliliter per kilogram fluid bolus or a lactate greater than or equal to 4. And based on the core measure, fluids should be given irrespective of concomitant disease states. The purpose of our study was to assess the safety and efficacy of guideline-directed fluid resuscitation in patients with end-stage renal disease and/or congestive heart failure at Princeton Baptist Medical Center. Our study was a single-center, IRB-approved, retrospective cohort study. Patients were identified by ICD-10 diagnosis codes as having severe sepsis or septic shock with ESRD and/or CHF comorbidities over a 3-year period. The CMS core measures were in place during the time frame of our study. Outcomes were compared between two groups, which were the guideline concordant group and the non-guideline concordant group. For patients to be included, they needed to be at least 18 years of age, have sepsis or septic shock with ESRD and/or CHF comorbidities, and meet one or more of the following criteria: initial hypotension, lactate greater than or equal to 4, or provider documentation of septic shock. Patients were excluded if there were conditions that would affect provision of care at the 3-hour mark, including not receiving antibiotics. Our primary outcome was in-hospital mortality. Secondary outcomes included ICU and hospital length of stay, number of simultaneous vasopressors and/or inotropes needed within 24 hours, and net fluid balance at 24 hours. We assessed 3 outcomes within 48 hours of time zero, which included new invasive or non-invasive ventilation, new or increased intensity of volume removal, and AKI. Lastly, we assessed shock-free survival at 7 days. Appropriate statistical tests were chosen. Pre-specified subgroup analyses were conducted for patients with CHF only and ESRD only. On the right side, 111 patients were included in our analysis. 62 of these patients were placed in the guideline concordant group and 49 patients were placed in the non-guideline concordant group. Baseline characteristics were fairly well matched between the two groups. Our average patient was about 70 years old and about half the patients were Caucasian males. The majority of patients in the study were diagnosed with septic shock. Lastly, patients in the non-guideline concordant group had a numerically higher SOFA at diagnosis and change in SOFA score than the guideline concordant group. And looking at comorbidities, the majority of patients in both groups had CHF only. For outcomes data over the next several slides, our guideline concordant group will be represented by orange and the non-guideline concordant group will be blue. When comparing our two groups for the primary outcome of in-hospital mortality seen on the far left, there is no statistically significant difference. These results remain consistent for both of our subgroups. Looking at the top part of the graph, we can see that the guideline concordant group in orange had a shorter ICU length of stay by almost 5 days as compared to the non-guideline concordant group in blue. Below, the guideline concordant group also had a shorter hospital length of stay by 7 days. Both of these outcomes were statistically significant. Now looking at our outcomes assessing volume overload, we see that there was no statistically significant differences for the outcome of net fluid balance, new invasive or non-invasive ventilation, or new or increased volume removal. However, the guideline concordant group had 13.7% of patients experience AKI compared to 43.3% of patients in the non-concordant group. This outcome was statistically significant. Lastly, our outcomes assessing hemodynamic support showed no statistically significant difference between the two groups. There was no difference in mortality between our two groups in the study. Additionally, no adverse outcomes were observed related to volume overload in patients receiving the recommended fluid bolus compared to those who received less. In fact, there was a lower incidence of AKI among patients receiving the guideline concordant fluid bolus. Our study also showed a shorter duration for both ICU and hospital length of stay for patients receiving the guideline concordant fluid bolus. Our study was not without limitations as listed below. In conclusion, this novel study suggests that patients who receive the recommended fluid resuscitation have a shorter ICU and hospital length of stay. Additionally, correcting volume depletion early in sepsis may outweigh the risk of volume overload. This includes the prevention of AKI, as we observed a lower incidence in our guideline concordant group. Thus, it is reasonable that all patients should receive at least a 30 milliliter per kilogram fluid bolus, regardless of whether they have end-stage renal disease and/or congestive heart failure. I would like to thank all of those that have assisted in this research and presentation.